Assalamu alaikum, everyone. Good day, and thank you for joining us today as a special webinar, as requested by many of you, to go through a new concept, which is part of competency-based medical education. Today, we will be talking about EPAs, Entrustable Professional Activities. So if you allow me, I will share my slides and let me know if you can see it all. Okay, so I just do thumb up if you see my slides. Excellent. So let's start presentation. So today I will introduce the EPA concept, covering the assessment rules, the framework for formal entrustment decision, and available assessment forms. My team will help you also to provide an overview of the implementation plan for EPAs. They will also give you a guide on how EPA will be applied for both trainees and program evaluations, and we will introduce the NIHS ePortfolio platforms and demonstrate how to complete EPA forms. So, quick introduction. The NIHS was established by cabinet decree as a national institution mandated to spearhead, regulate, and organize professional development for the health workforce, with a particular emphasis on specialty training. We're working on building up and strengthening the governance, the accreditation, the specialty program, and the assessment system. And our role is to set standards for institutional and specialty accreditation programs, accredit training institutions, conduct specialized professional examination, issue the board certificate, and approve the continuous medical education standards. I would like also to invite you to visit our website and look at our e-services, where you can apply as an examiner if you are a qualified consultant on the specialty with a good experience in education. You could also read our accreditation standards and look over our bylaws and standards. So when it comes to assessment, we have the residency entry examination, which are open for final year medical students, dental, and pharmacy residents. Most of the applicants so far are interns who are looking to enter our residency programs in UAE. We also have our Emirati board examination, both written, 2 parts, clinical examination, and today we will talk about the workplace assessment. So to be Emirati board certified, you have to graduate from an accredited program by NIHS, and you need to be signed off as a competent, entrusted for unsupervised practice. And today we will be talking about, well, how can we entrust, or how can the program director and the clinical competency entrust the graduates for unsupervised practice? Well, just to go through some history, there has been a global shift toward competency-based medical education, also known as CPME, focuses on outcome, what learners are able to do upon completion of their training, rather than the time spent in training. It emphasizes the development of specific competencies that are essential for the practice of medicine in today's world. Assessment that occur infrequently or at the end of rotation fail to provide timely feedback that is crucial for growth. They may not be adequate and they are not reflecting the residents' day-to-day performance on their ability to integrate skill across different competencies. And this is why today we will be talking about the workplace assessment and the entrustable professional activities. So the workplace assessment are an approach that evaluates residents' performance during their routine clinical activities. It focuses on direct observation and provide immediate feedback to support learning and professional growth. The purpose of the workplace assessment are to ensure that the residents develop the essential competencies for independent practice and to provide a formative feedback that guide the trainees in their learning journey and to enhance patient care by ensuring clinical tasks are performed competently. There are different types of workplace assessment, including the mini clinical evaluations exercise, mini CX, the direct observation of procedural skills, DOPS, the case-based discussion, CBD, and the multi-source feedback. And again, the purpose is to assess real-world competencies, to promote reflective practice, to enhance learning, and to ensure patient safety. The key features of the workplace assessment are authentic evaluations. The assessment most of the time occur in real clinical setting, providing a realistic measures of trainees' ability. The supervisors observe trainees performing clinical tasks, procedures, or interaction with patient and team members, and this is why it's a direct observation, and it also gave a formative feedback with a continuous process where they are conducting in a regular basis to monitor the progress and the development. And there are multiple assessment as well, comes with a multiple assessors utilizing various evaluators and tool enhances the reliability and validity of the assessment. Now, what about EPAs? So these are the unit of professional practice tasks that can be fully entrusted to an individual once they have demonstrated the required competencies to ensure them or to execute them and supervise. Most of the time, there are observable and measurable units of work that require integration of multiple competencies and aligned with real-world clinical responsibilities. The EPAs focus on assessing trainees in the context of performing real tasks. It comes with 5 levels. You could entrust someone to observe only. It could be an intern on their first week where you trust them to observe but does not perform the activities. There could be level 2 where they could act under direct supervision. And for some senior residents, they could act with indirect supervision. And level 4 is when you trust someone to act with distant supervisions. And most of the time, they could be just about to graduate. And the highest level, number 5, is to trust to perform not only independently, but they can provide supervision to juniors trainees. So the workplace assessment serves as the method for evaluating trainees' performance of EPAs. So the EPA defined what needs to be assessed, while workplace assessment provide the structure for how these activities are assessed in real time. The integration of EPAs and workplace assessments allow for ongoing dynamic assessment of competencies, ensuring that the trainees is progressing toward independent practice through observable behavior rather than just through theoretical knowledge. We're hoping to see the impact of implementing these two assessments by enhancing the medical training, by improving the evaluation based on performance in real setting, and ensuring a competency-based approach. And we shall have clear goals for both trainees and supervisors, contributing to a transparent and progressive medical training framework. With this, I would like to introduce our speakers for today's webinars, Dr. Theodora, who's an accreditation expert at NIHS. She will be talking about building and implementing EPAs. Dr. Fawziya, who's a medical education expert at NIHS, will talk about the key policies and regulation for implementing EPAs. And then Mr. Hanouf will talk about the NIHS portfolio, the guide to completing EPAs forms. I'll move now the mic to Dr. Theodora. Thank you. And we'll leave the question, if that's okay with everyone, to the end. You can, at any time, type your questions at the QA sections, but we'll open the mic toward the end of the webinars. Thank you very much.
Good afternoon, everybody, and thank you for attending this beautiful HOPE webinar in such a big number. I will go through a presentation regarding the building and implementing EPAs, and I hope I will convince all of you, if not possible then most of you, that it is the best way to build knowledge, skills, and attitudes with our trainees in order for them to be later on the best experts in their field. So to start again with defining the EPAs, they are a unit of professional practice, very, very well-defined activities in their practice that can be fully entrusted to a trainee only after they demonstrated the necessary competence to execute this activity unsupervised. So they have to become competent before being trusted. And competence means passing the threshold that allows for sufficient trust to act unsupervised. There are a lot of reasons why we think EPAs are the best way to assess learners in medical field. And everything comes about the trainees' needs. We have to make sure that they do receive enough support. And when I say support, it's about training, exposure, assessment, and feedback, very important, to become competent in the main domains of their practice. Also, it allows the PDs and the faculty to adapt the supervision level to the trainees' needs. So the trainees are not over-supervised or under-supervised. The supervision level is adapted to their growth and progression. There is a safe, stepwise engagement of the trainees in clinical practice. We don't throw them in the deep water once they graduate. We ensure that they know to swim when they graduate, so they can, go there in the stormy sea and they will know what to do. It allows the programs to use assessment tools which are objective and meaningful. We don't spend our energy without having a real purpose. And the trainees will graduate with a sufficient set of knowledge, skills, and attitude to practice at a high level and safely to our patients. To go again to the rationale of implementation, the EPA provides the trainee with a full understanding on how they are progressing, what are the requirements of their progress, and what do they need to do, what are the professional tasks. Also, there is a formal acknowledgement of their passing thresholds and allowed to decrease supervision. It also provides supervisors with a very solid justification for delegating activity to trainees. Because in the end of the day, it's a promoting system based on demonstration of skills, knowledge, and attitudes. So creates also a longitudinal view on each learner performance via an aggregated evidence. So we are seeing as they are completing their EPA entrustment, how they are growing into their activities. Next. During our activities and our interaction with the trainees, there are many events when we do ad hoc decision of entrustment. Okay, go and see the patient, take the history, call that doctor, or so on. Sometimes we do it without understanding the possibility or the competence of the trainees to perform the task. Now, when we are talking about EPAs, we do the decision only after they are demonstrating that they can do it. So again, we don't throw them in the water. We guide them first, teach them first, see them how they are doing, and then we can entrust with a decision or another. Unfortunately, and this is not the only publication which is red flagging this, for patient safety, residents receive less opportunities to execute real responsibilities for patient care. Because the administration is afraid, because insurance is not covering, because the faculty is afraid, because we don't have legislation, we don't have rules, we don't know what they can do. So what is the reason? What is the result? They will graduate poorly prepared for unsupervised practice. And then who's jeopardize? The patient care. So it's like a vicious circus. We don't allow them to do things, then they don't learn how to do them. And then when they become on their own, accumulating I don't know things, the patients are at risk. So one very important question, can I leave the theater? Can I leave my trainee to take over the activity I'm doing right now? That is a very, very important question. And the answer came in 2005 by introducing EPAs by Professor Ole ten Cate in Netherlands. And now the concept is flying around the world. When we are talking about the workplace-based assessment, we may have a retrospective look. Did the learner, past tense, did the learner learn everything I teach them? Did they master everything? Or we can go prospective through the EPAs, and we can say, is the learner ready to assume all the expected responsibilities in future? Okay. Now, when we implement EPAs and build EPAs, there are some very basic general rules. Each specialties must define the EPAs that are best suited to ensure the trainees progress through training. Then the number of EPAs for a specialty is determined by that specialty committee. We, at the level of NIHS, ask every single specialty to be fully responsible and committed to the building of the EPAs. The prerequisite for entrustment Can we go back, please? Yes. And decreased supervision progression must be very clear made for everybody. Okay. So how is this happening? At the level of NIHS, we ensure the database, the electronic log system, the logistic support, and of course, in the end will be the program quality assessment. And when we do the assessment, we will look at the EPA implementation. Now, also at the level of NIHS are the scientific committees which are building the EPAs, and not only building the EPAs, but later on, they will come and do the maintenance. Because once we apply the EPAs, we may find things we want to improve. So it comes back to the scientific committees to have this time on maintenance. The volume and the case mix, which is covered by the EPAs, is extremely important because they have to cover sufficiently, if not all, at least the majority of the aspect of that specialty or subspecialty. And this will include the variety of pathology or the case mix, including age-specific particularities, pneumonia in a newborn, pneumonia in adult, pneumonia in a geriatric, or in a pregnant woman. It's the same disease, but with really different aspects and particularities. Variety of skills, cognitive, surgical, or non-surgical procedural, and variety of encounters, acute, chronic, stable, unstable, critical, and so on. Next. So building the EPAs have to respect few steps. We have to make a very clear description of the EPA. What is exactly is that activity? What are the assessment tools? The grade of supervision and who is the one which will supervise? What is the basis for formal entrustment? How many documented encounters which are achieved need somebody to demonstrate for the faculty, for the PD, for the CCC to say, okay, that guy can do and can be entrusted to do that particular activities. There is also a very important aspect is when do we expect that EPA to be fulfilled? And then it's a list of knowledge, skills, attitude, milestones. Name them the way you want to name them, but what are the items we want the student or the trainee to demonstrate one by one when we are assessing an EPA? Okay, so I took here an example from anesthesiology, and that is performing a non-airway basic procedure in anesthesiology. So it's a procedure which is non-surgical. The description, this EPA includes selecting appropriate patient and technique for the procedure, taking the consent, performing the technical aspect of the procedure, documented, and manage post-procedural complication. And then it's an enumeration of the procedures: spinal, arterial line, central line insertion. Very clear. Then the assessment plan. Who's observing? Supervisor. Could be anybody who is entitled to supervise that trainee. And it's a direct observation. Now, when we are talking about the assessment form, we will take information about the procedure, of course, use of ultrasound, anatomical site of central line, and setting, OT, ICU, ER, or any other setting. And then what is the basis for formal entrustment? So the guy who wants to be entrusted, who needs to be entrusted, everybody, have to collect 20 observation of achievement, not any 20 observation, but 20 observation when that trainee achieved a certain level, which is level 4. In these 20, at least 2 have to be arterial lines, at least 5 central line, and at least 5 spinals. Then when do we expect them to master this EPA? Every committee will decide that. We don't interfere here. Now, why is it important to have this knowledge? And it's important for the programs, because there is a clear path of clinical achievement for the learners. They have to know the way, the cascade they have to complete the EPAs. They will not jump to the very difficult ones until they did not finish the more common or less complicated. Then it's very important to identify the learners which are outliners, either faster or slower, because the PD has to adjust the level of supervision and give the faster opportunity to develop further and help the slower to come back into the progress line. And also it alerts the learners themselves that they are not in track. And as I said, allow the PD to give the right support. It's fine. So how the assessment card will look like. So we have the trainee name and EPA title. It's like a quick reminder of what is this activity, the date of observation. And then you see it was a direct observation, and we have to click OT, ICU, and so on. So everything it was described in the beginning, it's here. It helps us to understand all the variables, the clinical variables on which the EPA was taking place, the activity was taking place. Then we have to hear the list of milestones or medical questions, clinical questions, knowledge, skills, attitude, name them. And here we have to decide if the trainee acted under level 1, 2, 3, 4, or 5. So this is what they did. And then we'll have feedback to the resident and the competence committee. It's very important to give immediate feedback to the resident or to the fellow, to the trainee. They did well. What did they do well? What did they do not so well? And what can be improved for the next time? For the competence committee, it is important to flag out if there were important happenings during the EPA, and mostly if there were professionalism or patient safety issues. If they were there, they have to be described and they have to be brought up to the CCC. In the end of the event, this is our overall observation, and this is how we think, yeah, the trainee can be entrusted. But this is only one event, yeah? This is only one. The CCC will gather all the events, and then based on the number and the quality, they will decide upon the entrustment. Okay? So the faculty assessment has to have in mind, you know, the levels of competence on the cognitive and non-surgical, about having knowledge, perform tasks under full supervision or with full involvement in the surgical, under moderate supervision or with non-essential involvement in surgery, perform tasks with condition independency or without supervisor present. It's at the side, or they will see the event tomorrow, the oversee. And then trusted to perform without supervision and can supervise junior colleagues. Okay? Okay, now there is a lot of audience there, and I'm happy to see the number. Take a few seconds, maybe not a full minute, and try to identify your place in a cascade of leadership and work. So find for you a role player between institutional leadership, program director, faculty, trainee, coordinator, and a member of a CCC. You can take more than one roles, but just from now on, try to think on the presentation from the shoes under the hat you just should have a choice. So let's go further. Now, you are nominated by yourself, the DIO or the CMO of the institution. Okay? So what are two important actions you need to do to implement EPAs? Can I hear? Anybody, DIO or CMO in the audience? Or who wants to be a DIO or a CMO? Nobody wants this role?
Maybe they can type on the chat, Theodora, and
Yeah,
you
that
can
would be
read the
nice.
chat. Yeah.
I agree with you. It's a very, very difficult position. So let's go further then. If nobody wants to give us their opinion, we think that DIO, the GMAC, and the hospital administrations are key factors in implementing EPAs. Because at the institutional level, they have to coordinate all the actions in the programs, all the happening regarding the EPAs. So basically, the DIO and the GMAC have to conduct the training and to be sure that these trainings are fruitful and targeting the EPA subject. They have to oversee the implementation, and very important, they have to create and implement a policy about EPAs. And this policy is just a common policy to all postgrad medical education programs in that institution. At the level of the hospital administration, they have to take that policy and they have to spread it throughout the institution and participating sites, because some departments may not be immediately related to the programs, but they have to know about the EPAs. And they have to acknowledge that the EPA system is representing the privileging activities at the postgrad medical education level. Now, we are coming down to the program level. At the program level, we have the PD and associate PD, of course. We have the faculty, we have the trainees, the coordinator, and very important, the CCC. So, who in the audience took the role of program director? Can we see what you think the two important actions needed for EPA implementation?
You can use the chat box.
Yeah, write in the chat. It's fine. I don't see any message. So can you please type on the chats, not on the Q&As? They say chat is not open.
Oh, there are a lot of questions on the QA, I think.
Okay, so I have here, Dr. Omar. Before anything, there should be an awareness of the faculty. Absolutely agree. Okay, chat box, so they don't open chat box.
We can use the Q&A.
But the QA is working.
Yeah, so work on QA. Write it here, please. So what we have now is that the faculty have to be aware. So definitely the program directors, PD to develop policy and guide. Absolutely, absolutely, totally agree. So they have to develop the policy at the level of the program. Train the faculty, absolutely, agree. What else? Very good. So let's see what we wrote. And if you still have ideas, please write them on. Teach the fellows and residents. Yes, they have to teach. They have to teach.
I can see more responses, Dr. Deodora. Can you see? Implementation, standardize the EPA, clear-cut policy, trainee
Standardize the
orientation.
EPA, training orientation, yes. Implementation, yes. Site coordinator. The coordinator has their own tasks. Time to implement. Well, the implementation is as we go. Stakeholders' opinion. Okay.
The chat's working now.
Okay. So let's state the chat. Assessments they have to do. Teach fellows about it so they will understand. Yes. Good. So let's go to our answers. Next slide. Yes. So you see here, I put on red, create an EPA policy specific to the program. That is very important because in this program, in this policy, that is the enumeration of all important tasks for the faculty and for the fellows, the trainees, to know regarding the EPA. And also, it tells them when and how is the decision process going on. Remember, the PDs, they do have the possibility as being part of the scientific committees to build the EPAs. So they may be part of the very initial decision on how the EPAs look like. They have to make a curriculum which is built around the EPAs. So they teach having in mind the have to do task later on. Align the EPAs with real practice. Absolutely, that is done with the scientific committee. And if you think that the EPAs resulting from there are not aligned with the real practice, please communicate with the scientific committee, because remember, they can do the maintenance. Okay? The PDs, they have to maintain a very transparent platform of implementation. This is not a hidden object. Everybody needs to know what is happening there. And of course, distribute, and you all agreed on, the needed information to the faculty and trainees. Very good. Let's go further. Next slide. Okay. So you are not a PD, but you are a core faculty or a supervisor. What do you think it's at your responsibility level to do for the good progress of EPA implementation? Okay. Provide direct observation and feedback. Well, that is a key. That is a key. Okay. Identify the level to guide. Yes, supervise an implementation. Integrate the curriculum and align. Supervision. Yes, evaluate the training. Absolutely. Follow the policy. Yes, but we are not just followers. We are thinkers. Yeah. Determine the required skills. Yes, absolutely. Continuous feedback. Brilliant. Train the faculty. Yes, faculty can train the faculty. Of course, because we are learning from our peers. Doesn't matter which level. Proper assessment and evaluation of interns with EPAs with feedback to interns at CCC. Correct. Engagement. Absolutely. Learning objectives. They have to identify them. Attach the just the teaching method with the EPA requirements. Absolutely. Curriculum engagement. Wow. Training, yes. Adjust teaching and learning to achieve the outcomes. Yes, brilliant. Feasibility, I'm learning from you guys. You are very, very good. Follow the rubrics. Yes, they are there to be followed. find the teaching methods, research compliance, handle interns with difficulty. Yes, 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 yes. Explore EPA from literature. Why not? We have to learn from others. I don't know what TOT is. I'm sorry. Utilize tool design, measurement, performance. Yes, continuous evaluation, and so on. Very good idea. Identify strength and, yes, weakness, because we are watching our trainees, so we see if they are struggling. Very important. The impact of EPAs on the patient. Yeah, we will see that. Continuous feedback. Yeah, that is really, really, I can't underline how important it is. Sustainability initiative. Why not? Handling interns with gap of practice. Yes, and so on. We will collect all these very good ideas and will distribute them to all. So let's go to see what we said. So basically, we think that faculty has two very important, many others maybe, but these are the main important tasks they have. They have to supervise and they have to assess. It's a formative assessment. So they should ensure multiple information when they do the assessment. The number of assessors, the event and the environments, the clinical environments. And in the assessment, it's this very important thing, immediate, meaningful feedback. What they did well, what they did wrong. Because there and then, it's the very hot moment when the trainees assimilate advices. They know if they did well, they know if they did wrong. They feel it, but they want to know from the supervisor, what can they do next? What can they do further? They are trembling to know your opinion. So give it to them, honestly and meaningful. And of course, you have to document your assessment. Very good. Now, I hope that we have some young people there, some trainees, and please tell me what are the actions they need to take when we are talking about EPA implementation. So let's see some very young blood giving us their opinion. I hope I will be a resident again. Need to understand the EPA assessment of skills. Yes, identify the learning needs, very important. And this takes a lot of energy and thought. Readiness to learn, awareness about importance consistently. Yes, be prepared, very good. Be present and observe. Yes, why not? They can be there when somebody else is having an EPA and learn. Yeah, we can learn from our peers, absolutely. Provide guidelines, okay. Clearly clarify the expectation and doubts. Yes, accepting feedback, they have to. And I'm telling you, they want feedback. Need guidance, yes, observation. Be a team player. Yes, I agree. Writing the EPA activities, yeah, but it's the assessor, the one which does the writing. Basic reactivity and innovation. Why not? Open to learning. Yes, self-assessment. Learn, reflect, and perform well. Yes. Active learner. Very good. Identify gaps. Yes, they can. They can do that. Because the first which will know things were not done right is the learner. Yeah. The first sweating will be the trainee. Critical thinking and active learning how, okay, sense of ownership. I totally agree. This is very important. Sense of ownership. Yes, they have to own that. Very, very good. So let's go to what we put there as important actions. So acknowledge all aspects regarding EPA, obtain an assessment or documentation, ask for immediate feedback. If it's not given, the trainees, they have the right to ask for a feedback. Maintain the clinical activities record through the logbook after entrustment. This is very important. after they learn how to do a cesarean section or to intubate or to insert central line, they have to keep up the record with their further activity, because it's not only the learning curve, it's the experience volume, and that is as important as the learning part. Submit the forms to coordinators if the organization is choosing this way, and actively follow their progression towards entrustment. And one more thing I would add here: have the ownership of their own skills and knowledge is extremely important. Okay, let's go further. Let's say there is a coordinator in the group. What do you think it's important for coordinators to do to help with the EPA implementation? Because I can assure you, they have a very important role. So, what do you think? Database maintenance, yes. Facilitator, yes. Logistic, safe environment, proper planning, yes. Appropriate, yes. Coordinate the EPA's activity, ethics, have a tracking system, very good. Prepare evaluation forms, track progression, follow up, absolutely, absolutely. Maintain EPA forms, scheduling, mentoring, communication, banking of EPAs, reviewing feedback, very good, very, very good. Consistency, encourage, yes. Reminders, liaison, yes. Ensuring quality assurance, yep. Good. So let's see. Point of contact, very important. Yes, it's important. Engagement in the program, absolutely. So maintain assessment records, prepare the target assessment and present them to the CCC meeting. Maintain the updated correspondence before and after the CCC, because it's a full discussion happening before the CCC, during the CCC, and after the CCC meeting. The CCC is not there somewhere suspended in air. There are a lot of actions around it. And of course, maintain a record of minutes, the CCC meeting minutes, because that is the very clear justification of their decision. That is the hot discussion about the members of the faculty, about that person and that activity. Very important to maintain the minutes. And mind you, I remind you, the CCC is the only committee in the residency program where trainees are not having access. So we have no trainees in CCC. It's only faculty members. Okay, let's go next. Now we are in what we talked about, CCC, and you are a member of the CCC. What important actions do you need to master to do for the EPA implementation? So any faculty can answer to that. The PD may or may not be part of the CCC, or you could identify yourself as a CCC member. So let's see what are the activities. Okay. Feedback in turns must be considered and discussed. Where I am here, standard performance tractive, identify required competencies, framework, standardizing, ensuring that EPAs are aligned with the curriculum. No. Providing constructive feedback. No, this is the PD. Reviewed EPAs and evaluate. No, they don't have to review. They have to review the assessment forms. Converting milestones to EPA. No. Summative rubrics and check. Ensure consistently specify the aims. Accreditation. No. Evaluation of trainees. Evaluation. Yes. Yes, that is what it is. Report to the PDs for interns needing additional training, could be remediation plan, that is after. Check off all the elements of competencies. To have a look to the how much they complete. Yes, ensure fair clinical exposure. This will be after. Support the PD, of course. Objective evaluation, yes. Promotion to next year. They will suggest it to the PD, but the decision is for the PD to take. Feedback of evaluation to the supervisors, support and guidance. Okay, let's go to our answers. So basically, all the CCC evaluation are going to the, so all the EPAs evaluation, sorry, they will go to the CCC committees meeting, yeah? So they will meet and they will say, trainee Dora, me, yeah? For the EPA 1, completed 10 evaluations, out of 10, reached achieve evaluation in 5 cases, okay? And it's required for trust only 4 achievements. She achieved 5. So shall we entrust her? Yes or not? Okay. Trainee Dora, EPA number 2. It was assessed for 10 times. Expected trust is if she complete 15 evaluation at achieved level. She only has 10. Shall we trust her? Yes or not? So this is the discussion happening in the CCC. Okay? So basically, they will consider the level of proficiency for each observed encounter and the number of events executed as a certain level of supervision. Based on this, they will propose the PD the level of entrustment for each trainee and for each EPA. Then they will report negative gaps between the projected, you know, remember we said we expect them to complete the EPA at a certain time, let's say in the end of year 1, yeah? So they will report if there is a trainee which is already in the year 2 and they did not complete the EPAs projected for year 1. This is a negative gap, yeah? And then analyze and propose to the PD the advancement into the next training level. So the CCC, it's a collecting volume of supervisors, brains, very good faculty, which are keen to observe and to collect all the information and then propose to the PD a decision. Now,
لا صح.
yes. Okay. So now imagine you are sitting in a CCC meeting. There is an EPA, the anesthesia EPA, which I just described, the central line insertion. And we have these 6 possible scenarios. We have the trainee number 1, who completed 75% of the cases, which is 15 cases out of 20, but all of them were at a level 4 or 5. So did independently or even taught some of them. We have the next one, which completed 150%, which is 30 out of 20 assessments, but the level was between 3 and 4. We have the third one, which completed 100% volume at a very good level, yeah? But there is a documented safety or professionalism severe issue. That guy had a very inadequate, rude communication with the team. in the milestones which are described under that EPA, there is nothing about communication. So the assessor could not, select one of the milestones because it was simply not there. So he chose to communicate with the CCC through that note. The guy, the trainee was rude and had a very inadequate communication with the team. Then it's the number 4 trainee who completed 100% volume with the level 4. But you remember there were 3 procedures there. He only has 2 procedures. The third was not done at all. Then number 5. Somebody says that there is no sound. Number 5 has all 20 assessment documented by 1 faculty only. 1 faculty only. There are a lot of faculties there, but that trainee somehow has all the documentation done by 1 person only. And then is the 6th one, which did not complete the requirements, but it's already in the PGY 3, while this task had the EPAs had to be completed at PGY 2 level. I'm just giving an example. So I'm asking you, as a CCC member, to which of them would you give the entrustment? Or let's make it easy, to which of them you will not give the entrustment? 1, 2, 3, 4, 5, or 6. So would you be impressed by the quality? Would you be impressed by the volume? Would you be impressed by the note to the CCC, the incompleteness of the case mix, the possible problem with 1 only faculty member and possibility of a bias, or, well, it's already advanced, let them give it. So let's see. You will not give 2. Oh, I can't see it. Yes. Except 1, 3, 3, 5. Okay. 3, 3. So professionalism is important. 5, 3. Give to 4. Okay. I'm concerned with all except number 4. Okay. 3. Okay. Guys, you are very good members of the CCC. Absolutely. Absolutely. So let's just discuss. I was a PD, so I will give you my humble opinion. For the one who completed 75% at the level 4 and 5, I think I would give the entrustment because, the number, it's only an advice. From our side, that number, it's an advice. But at the CCC level, you know your trainees. You know them. You know much better than we do. That is a theoretical number. It's just a guide. But if you have somebody who's outstanding and they demonstrated again and again that they are good, you have to give sometimes a wild card. So I would agree with the T1 to be given. When the T2, I shall look into the progress in that 30 cases. Because if the first 20 cases were level 3, and then the next 10 cases were, level 4, it's a very clear improvement. Maybe I would give another chance for 10 more or 5 more and see how it works. But if the first cases were at level 4, and then the guy falls down into the levels of expertise and falls into the level 3 or less, something happens to that trainee. So maybe that trainee is a cry for help. So we have to look into the progress. Then for the T3, I agree with all of you. A very clear note for the CCC for an inadequate communication or any issue regarding safety and professionalism has to be taken seriously. So that trainee needs to have a one-to-one session about what happened and, an analyzation of the event, and that has to be taken separately. Would we trust him to do the procedure? Maybe yes, but after they will learn and they will repair the bad, attitude. Completed 100 with level 4 with the case mix incomplete. Maybe I will give something like a condition, just giving an opportunity. Maybe they didn't have the opportunity to come across that case mix. So we have to select 1-2 cases, give them the opportunity to also tick that box and give the trust. I agree. Documented by the same faculty, here I have a problem, because I'm sure in the full volume of faculty members, there is more than one person who can do the assessment. So I can't say I don't trust my members, my faculty, but I would like somebody else's opinion as well. So I think here I would give, the opportunity for somebody else to assess and to give the opinion. And for the one who did not complete the requirements, but it's already advanced at a higher level, well, that is not a reason to allow them to do things they are not prepared for. I don't think this is a reason. We have to recalculate their progression and their promotion criteria. Okay, let's go further. Now, the circle close or come back to the PD, because after the discussion in the CCC will give the PD an, full range of advices on how were the EPAs completed and what is the level the learners achieved. But based on the recommendation, the PD is the one which ultimately decide the level of entrustment. The summative evaluation must be communicated and discussed with each trainee. They have to analyze together the negative gaps. They have to put down a remediation plan, and it has to be formulated and implemented to the trainee needs. If they are severe or multiple negative gaps, this EPA activity can be used as a justification, for non-promotion or even dismissal from the training program. Of course, after we give a remediation chance, and if that remediation is not even that clarified, then that could be a justification. And absolutely, in the end, all this activity will be reported to the trainee file, and this is transparent to NIHS level. Okay, so we already discussed them. I gave you my opinion, but if there is a PD in the forum and they don't necessarily agree with me because I just gave an opinion, do you think you should just other way? I'm waiting to see if there is any other idea. Do we need to evaluate personalities? I don't understand the question. So do you think that other people should be given entrustment other than number 1 and maybe number 4, number 5? to be given the entrustment number 3? Okay, I doubt, but it's your decision. You are the PD. All right. 3 and 4. Okay. So I'm happy nobody gives entrustment to number 6. I'm absolutely happy, because this is a mistake which is done mostly when you have a change in a PD, and the new PD it's having a new complete new group, new for them, and some of the trainees, they were promoted before, and you understand, oh my God, what am I doing now? These guys promoted him or her without making sure that they can do this or do that. What am I doing? Do I demote? Do I dismiss? Do I do what? So this is a very, 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 very difficult situation. Okay, let's go further. Good. So basically, the level of confidence we have in our trainees, the levels of entrustment is 1 to 5. Yeah. We trust somebody to observe only, but that means that we trust them have enough knowledge to understand what they are doing, what we are doing, sorry. So observation, it has to be taken as an active observation. While we are doing a procedure, an activity, and somebody is an observer, we have to make sure through active interaction that that person have the knowledge to understand what is that activity about. Yeah, it's very important. It's not a passive observation, it's an active observation. The second level would be act under direct supervision. I'm here, I'm watching you, you are doing, and my hands are near your hands. If it's needed, I will take over. So it's a very close supervision. I'm here to take over. Don't you worry, I'm here. So the patient is not at risk. Act under direct supervision. Act under indirect supervision or on request, very quickly available faculty. Yeah, I'm maybe over the curtain. The curtain is between us. I'm next door, but you can call me anytime. I'm here, maybe not, watching you, but I'm here. Any question? You are seeing a patient in the clinic, you have a question, call me. Yeah, you are scrubbed, you cut the skin and you are unsure, I'm scrubbed, I will enter. So very, very close still. Number 4, act with oversight supervision or post hoc. I did the event as a trainee. I encountered no problems whatsoever. I managed everything to A, from A to Z. And my supervisor will come tomorrow and see the notes and see the patient, and everything was done. We'll read the notes, my operation, everything will be seen after. And then I'm trusted not only to do, but I'm trusted to teach somebody junior than me how to do that task. Okay? Further? So I finished here, and I hope you will have a lot of questions, and I'm waiting you for the Q&A session. Thank you very much. I'm introducing Dr. Fuzia. She will take you further to the policies and regulations and implementation.
Thank you very much, Dr. Theodora. I'm delighted to connect with all of you today through this webinar. So good evening to you. It's exciting to see how actively you have been participating with the webinar that's been going on. Look forward to your participation in my session as well. It's a very short session where I will be just talking to you about what is our plan for implementation of EPAs for this year, and some regulations and the practice. In practice, what happens when someone has been entrusted. And then we will do a very short exercise at the end, and we will hand over to Ms. Hanouf. So to start with, let me just explain to you what we have planned for this year. We have been preparing the EPAs for several specialties. More than 19 specialties have got their EPAs ready and approved. Out of that, for 16 specialties, we will be starting implementation this year. These 16 specialties include 43 programs and over 1,200 trainees. And these are the specialties listed here, which we will start this year. Now, one thing which I would like to tell you about is that our implementation has been delayed a little bit because of the administrative processes that it has to go through. But in the meanwhile, what we plan to do is that we will update ourselves about the requirements of EPAs, about the actual EPAs, which will be distributed to the trainees so that they are aware of what their requirements are. And by whatever means you can, maybe by just on Word document or maybe on paper, just try to start implement and to be prepared for it so that when we start, it will be very easy and smooth for everyone. And that's why we have been conducting this webinar, and hopefully we will do more to keep you updated. So before I give you the policies, let's talk about the software pilot that we had run till December. Four specialties, 3 medical specialties, including internship, participated in this software pilot, which we conducted. There were 8 programs for these specialties, and they were spread out in 4 centers. 144 residents were included, and it was run for 12 weeks. Next slide. Now, the results of the pilot show that the trainees and the faculty think that EPAs actually did contribute to learning, which is a very positive sign. You can see over 80% were satisfied with the way EPAs were useful for learning, and they all felt that written feedback was very helpful. We made a lot of changes based on the feedback. We have categorized the EPAs by phases. We have made the app streamlined, and we have been trying to solve the problems of login by making sure that it will go through the UAE pass, and that would make it seamless. And this will be implemented by the end of this month. We have also made a lot of fine adjustments to the dashboard for visualization and for reducing the time lag. And we have given more control for the program director, and we have tried to facilitate smooth transition from one device to another. Now, all these are being settled, and we hope that we will be able to start very soon. Let's move on to the next slide. Now, what I would like to tell you about is that as soon as we launch, we would like to make this EPA mandatory. It will be mandatory for the year in which you are training for, and it will be a requirement for you to be promoted to the next stage of residency or fellowship wherever you are. You know, EPAs are very important, and we made it mandatory because they address the natural question that clinicians ask themselves on a daily basis. See, if you look at a clinician, when they start their practice and when they see their junior join, maybe it's the intern, it could be the resident, it could be the fellow, the first question that comes to their mind is, can I leave them alone to do this task? To what extent can I entrust this fellow to do this task safely and competently? So these are the questions which they are naturally asking on a day-to-day basis. And what EPAs do is to just document the same questions which are being asked by clinicians and make it a good feedback for the residents and the interns and, of course, the fellows. From now on, I'll refer to them as trainees, so that the trainees will know exactly where they stand and where they need to put more effort to improve. Just as Dr. Theodora said, the best way to assess a competency is by using EPAs, because this is the natural way and this is the workplace-based assessment which happens on a daily basis, and these activities are required for demonstrating competency on in the clinical practice. So we encourage trainees to exceed the minimum requirements for EPAs or case logs so that it will enhance their knowledge, skills, and attitude, and it will build confidence. So what it does to the trainees is that they become more confident once they know that they are being entrusted by their colleagues, by their seniors, by the supervisors, and also the patient. In order to make it easier for you, because when we say it is mandatory, you might think that it is a task, but this is going to benefit you. And we are going to build in a lot of flexibility into the process to reduce the stress and to ensure that the focus is on achieving meaningful competence. It's not just ticking boxes. The next slide. We have also linked it with program accreditation. So when the programs submit the annual reports, it should include their achievements in completion of EPAs as well. And this will help the program to make sure and demonstrate that they have achieved higher standards. And this is a mechanism to help them to monitor compliance with accreditation standards. Yeah, can we move to the next slide? Now, when I said that it is mandatory, you would be thinking, and I have received some questions from some of the interns and some of the residents who are in the final years of their residency. Will they have to complete all the EPAs which are required for their specialty within the same year? Now, we understand or we expect that they have reached the stage after completing all the activities which they need to complete, and they would have been assessed already based on the previous promotion rules. So on the EPA platform, what we expect you to do is the EPAs required for the current year. And we do not expect you to backtrack and just go back and as a ticking exercise to fill those. You know, at the end, at the semi-annual review and at the end of your training, the CCC will review your performance on a case-by-case basis, and you will be identified whether it can be acceptable or not. So this is one point which I wanted to make, and we have followed the best practices across the globe. Now, Dr. Theodora has already mentioned, but as these are the policies which need to be followed, let me just say it again. The institutional policy should include all the requirements of EPA, all the support that is required for the EPA framework to be implemented has to be clearly articulated in the institutional policy. So the existing institutional policy should have a part where EPA is also covered. Similarly, the plan that you may be having strategic plan, annual plan, should include adoption and implementation of EPAs. And there should be a clear monitoring plan for assuring the quality of implementation of EPAs. Now, before we go to the details, let me just find out how many of you have actually implemented EPAs already. I know there has been some specialties which have been implementing EPAs, and also we have done the pilots. So I would just like to know how many of you have been. So I feel that let's use something else. Let's use the raise hand icon. So if you could raise your hands if you have used EPAs, let's see if that works. Just like to know how many of you have actually utilized EPAs? No hands up? Or doesn't it work? Oh, yes. And that's it. Is this true? Has nobody used the EPAs before? If the raise hand icon doesn't work, you can put it on the chat as well. If you just say, yes, I will know. In the process of making, yes, we raised the issue many times. In nursing, we do not use it. So, okay, in that case, I think I will just go through, summarize what has been already very clearly described by Dr. Theodora. Now, for implementing the EPA system, we have a 3-tier organization structure. So I can see very few of you have actually implemented it, but I'm sure that all of you are familiar with EPAs. So our implementation will be at a 3-tier level. So there is the NIHS, which is organizing the platform and will be coordinating with the scientific committees to prepare the EPAs and to make sure that they are aligned with the competencies required for the specialty, and the quality of the EPAs will be assessed by the scientific committee before they are approved. So at the institutional level, we have the DIO and the GMAC who will make sure that the policies are implemented. And to support the institutional level DIO and the GMAC, we have the institutional coordinator. So every institution has an institutional coordinator who has been communicating with the NIHS, especially in the pilot study phase. And this institutional coordinator, in turn, will also collaborate with the program coordinators for individual programs and make sure that implementation is seamless and there is no obstacle. The most important members for the implementation of the EPAs will be the program directors. The program directors and their assistants will be the ones who are taking the brunt of the responsibility of implementing the EPAs among the trainees. So as I told you before, the trainees include interns, residents, and fellows. So this is the one point which I wanted to tell you. The institutional coordinator is the contact person with the NIHS. So if anybody has anything to be communicated to the NIHS, it would be the institutional coordinator that you have to go to. Now going to the next slide, we have just put some steps for implementing EPAs at an institutional level. Now, Dr. Theodora has clearly said how each person's responsibility at every level is different. Now, when it comes to the PD takes all the responsibility, and the PD has to define at the beginning the total list of EPAs required for this specialty. So throughout the period of training, what is the number of EPAs which have to be completed? So the entire list has to be communicated with the trainees and with the faculty. And in fact, these should be discussed and developed in collaboration with all the stakeholders, ideally. And this is how they have been developed for the 15 specialties that we will be implementing already. And it has been taken, a lot of care has been taken to make sure that they're aligned with the competency frameworks internationally. They have been made, it has been made sure that they align with the ACGME milestones and the CANMETs, so that you are familiar with the tasks, the real tasks which you find under each EPA would be what you have already been following. After the total list of EPAs have been defined, the next step would be to categorize the EPAs by the phase of training or the year of training. So for each year of training, there is a particular list of EPAs which have to be achieved. We would like to have the trainees to try all the EPAs which is possible to them. So they will have to do more than this. They have to exceed the minimum requirements, as I told you earlier. But they need to make sure that they have achieved these EPAs in this particular year. So there are some EPAs which have been designated so. If you look at the EPA forms which are already on the website, I hope all of you know that the EPAs which are approved are there on the website. And if you go to the website, you will find the details of all EPAs along with the tasks which are included under each EPA or the milestones. So when you go through those sections, you will find it has been clearly marked out when, at what time, this EPA has to be achieved. So to make it clear for you, we have a table. Ms. Hanuf, can you go to the next slide and then we can come back again? So this is an example where we have all the EPAs listed here, and we have 4 tables here. So considering internal medicine is a 4-year residency program, so PGY 1, 2, 3, and 4. So you can see that these are the EPAs which are mandatory to be completed at the end of PGY 1. And these are the ones which have to be achieved by the end of PGY 2, and these for PGY 3, and these for PGY 4. We hope that this will help you to focus on what's more needed and which one you have to achieve at every stage. And this will actually help you to manage your workload. Shall we go back to the last slide? So this is one important task that the PD has to do to make sure that they are categorized properly and they have been, the trainees have been made aware of what are their requirements for this particular year. So they will be able to set their expectations and they will be able to create plans to achieve their goals. The next step for implementing EPAs, as far as the PD is concerned, would be to integrate the learning activities of their specialty with the EPAs. So the curriculum and the learning activities which are existing should be linked to the EPAs which are required for that particular year. And the assessment tools and entrustment levels have to be clarified to all the stakeholders. The next step, I would say, is to make sure that there is adequate faculty development and make sure that the residents are oriented very well so that we have engagement of all the trainees. Once they have, when they are engaged and once they know that they have to fulfill these EPAs during their period of training, they will be able to set goals for themselves on a personalized level as to what they would like to achieve in this month and the next month and the next month and so on. Or, for example, in a particular rotation or in a particular semi-annual goal and so on. So this will be very helpful if the program directors communicate with the trainees with them at the outset, at the beginning of their training. And of course, there should be regular assessments and feedback mechanisms which have to be incorporated into the program. Let's go to the next slide. The other responsibilities of the program, just as we said that the institutional level policies should include the EPAs and support for EPA functions, the program policies should also include clarity on when and how the EPAs have to be completed. It should include a list of the EPAs itself and the role and what is the role of EPAs in promotion decisions should be intimated, and they should be informed by official communication about their expectations regarding EPAs. And it should be included in the policy folder and should be provided to them at the start of their training itself. Now, if we are launching it while they are in year 2 or year 3 or any other year, at that point, it should be included and they should be intimated. And this should also include timelines of assessments. They should know that there's going to be a 3-monthly CCC or a semi-annual CCC where you will be assessed and your entrustment will be informed to you and it will be available to you on your dashboards. These things should be clearly intimated to them, and this is the responsibility of the program director. And NIHS will, of course, support you in all these. We will have sessions where we will be orienting all the stakeholders about what they are required to do. The program directors should also monitor submission of progress reports, and they themselves have to make sure that the decisions have been submitted to the e-portfolio on time. So once they submit it onto the e-portfolio, the resident will be able to know that they have been entrusted for this particular task and that they are permitted to perform this task at the workplace. Next slide. So I have just detailed the different documents which need to be provided to the trainees. As I already said, a full list of EPAs, a list of mandatory EPAs for that current year, the dashboard displaying all the completed EPAs and the incomplete EPAs, then the case log summaries, whether they completed so-and-so or whether they need to do how many of the case log activities they have to complete within that particular residency program. All these should be available to them, and they need to know about the promotion criteria, which will also include the EPA completion, along with the other criteria based on which they are being promoted. And regarding communication of the regulations, the PD shall make sure that there is official communication that completion of EPAs is mandatory for them to get their CCT and that all regulations will be enforced, and the information on EPA expectation, including reminders and warnings if required. Shall we go to the next slide? The resources and support which has to be provided by each program has also been listed here, just so that it can be used as a reference. But I think all these things have already been mentioned, except for the training opportunities, mentorship programs. And the mentorship programs are very important. What has to be done is that the faculty members have to be trained on how to give feedback and how to be mentors to the and to be guides and to coach to the trainees. And a mentorship program would be very helpful for the trainees to be able to fulfill the EPA requirements. Shall we go to the next slide? I think Dr. Chidora has completely covered this in great detail, so I hope you already know this. We would like to have these CCC meetings at a minimum of 6 months at least. The recommended time would be 3 months. And during that, and you know that all the EPA is in the progression will be discussed as an additional tool in assessing the trainees. And the number of observations, as Dr. Tirora very clearly explained, would depend upon the discretion of the CCC. And whatever the CCC and the program director decide, that has to be documented in the residence files and should be made available for the trainees if the portfolio is not there. Even if the portfolio is not there, the residents have to be made aware of where they stand, which ones have been, what is their level of entrustment for each ones, and these records have to be updated by at a minimum of 6 months, and the level of trust achieved by the resident or fellow in each EPA and the time at which they achieved 4 or 5. 4 is the threshold. So if they reach 4, that means they can be permitted to perform that particular EPA independently with indirect supervision. So if they achieve level 4 or 5, that point also should be documented. In practice, there are some points which I would just like to clarify. These things have been already mentioned by Dr. Theodora in passing, but then let us just clarify what happens when someone is and has achieved the level of entrustment. So if you have to have a valid entrustment decision, this entrustment decision or the scoring should be done by faculty who are trained on EPAs, and their documentation will be very important, especially for surgical skills. When there are complex procedures which require surgical skin incisions and they need appropriate supervision, a supervising physician can authorize the operations to be done by these trainees who have already achieved the level of entrustment. And this decision is made on a case-by-case basis. Sometimes the supervising physician may not feel comfortable to hand over a procedure to a trainee, even though they have achieved 4 in the last CCC meeting. So it varies and it depends. It is at the discretion of the supervising physician anyway. Now, the name of the supervising physician has to be on the informed consent and in the operative note, and the level of supervision will be included in the patient's chart. How much supervision was given should also be included. So documentation is the key. And let's go to the next slide. And in some situations, you will find that in emergency situations, residents are permitted to do anything possible and everything possible to save the life of a patient. But he has to contact the supervising physician immediately after that, and documentation should be complete. For therapeutic and diagnostic procedures, most of the therapeutic and diagnostic procedures, if they have achieved entrustment, they can perform. And the supervising physician again has the discretion to decide whether he can permit the trainee to perform it with or without immediate supervision. Let's go to the next one. Now that we have come to, we've been talking about implementation of EPAs in several ways, I would just like to ask you some questions. So on the chat, if you would like to answer these questions, there are 2 questions here. Who initiates assessment and what are the types of observations that you're talking about? So if you could write whose duty or who initiates assessment in the normal course, can you give your comments on the chat box? Who do you think initiates an EPA assessment? Is it the trainee? Is it the supervisor? Is it the faculty? Residents, core faculty, trainee, supervisors, resident supervisor by direct observation, resident, clinical supervisor, faculty, GMEC. No, not GMEC. Of course, not GMEC. I'm talking about in the clinics. In the clinic, when you are assessing the EPA. Imagine that the e-portfolio is on the device, and then who initiates? Faculty. Faculty training himself. Very good. So you have a very clear idea. So can you click once? It is both. The answer is both. Let's see the answer. Both the residents and the teaching supervisors, both of them. But it's ideal to encourage learners, because the learner should take control over their own learning. So if the learner identifies that there is a case where I can demonstrate my EPA, or sometimes it is the supervisors, the faculty, they know that there is a procedure to be performed and they feel that they can let the trainee to train. Very good. So, okay. There is no sound. Someone is saying there is no sound. Is it soft? Oh, okay. Now, what are the types of observations? Dr. Theodora was talking about the different types of observations which are there. Can you just note on this chat box once more? Direct and indirect. Perfect. Perfect. That's it. You guys are really good. Okay, then Hanuf, let's see. That's the answer. So we have direct and we have indirect. And if you are directly observing, that's the best way of performing an EPA. Indirect is also possible, and examples of indirect would be if a resident comes and discusses about a communicated treatment plan already, or it may be a work product like a chart or a slide which has been prepared by the resident, or patient charts which have been prepared by the residents. This can also provide valuable ratings. Now, how do you identify EPAs? Where are the EPAs? Where will you find the EPAs from? Yes, Anif, I think due to, because we are yeah, we are almost out of time. I will not use more time. So the first way to identify EPAs when it comes to the educators would be to prioritize the key competencies for that phase of learning. But on a daily basis, what is the task of that day? Just ask yourself, what is the task today? And that's your EPA. All that you do on that day, that becomes your EPA. And who is it that assesses? Faculty. Faculty and other seniors who are assigned by the program director can be the assessors. In some cases, feedback from colleagues, nurses, and other interprofessional staff will also be taken by the surgeon before he gives feedback about a particular training. Let's go to the next slide. Now, who fills the form? Have you any idea? At the beginning, it's a trainee who fills the form. So there is the initial part of the form, which includes the type, the setting, the conditions, the case mix. And after filling all this, he hands over the device to the supervisor. Then the faculty scores on each milestone and then scores on the overall. And the most important part is the feedback. And the feedback will be verbal as well as written. And when do you sign off? Now, our plan is that you will be able to sign off immediately, then and there. So it will be real-time assessment and you will sign off standing in the wards. Now, if you are very busy or if there is any problem, you could also send it as an email to yourself and it can be done later on. And how many observations? I think Dr. Theodora already covered. There is a guideline which you will find on the EPA form, but these numbers are just a guide. These numbers are not hard and fast rules. The CCC can override the numbers. Now, if you have not reached the numbers, but you have been performing extremely well, the CCC can say that this candidate is can be entrusted. So it can be achieved. It can be awarded. Now, this is a very big question and there is no clear answer for it. How do faculty fit the observations in practice? Now, the truth is that in the work week, all the small tasks which you are observing, which has to be done and which has to be observed, these form the EPAs. So it is not an additional task, hopefully. The only problem is sometimes you find that the trainee works in parallel with you and you have your own work, so it is difficult to assess while the work is being done, and you may have to do some adjustments to make sure that observations fit into your practice. Now we will talk about the importance of feedback and coaching. Now, to make it very short, I will just summarize. It has to be timely, constructive, and specific. It has to be honest and encouraging. And it should be focused on observed behaviors. And it should be compared with performance standards. And when you give feedback, make sure you give positive reinforcement as well. It's not enough to say where they need to improve, where they did something wrong. You also need to tell them that you did this well and you have to continue doing it this way. So this will be very helpful, and this is required for trainees at all stages. At all stages and levels of competence, it's required. Now, in literature, you will find that, next slide, you will find that feedback is a critical component of formative assessment, and it's not enough that you do the written feedback. Verbal feedback is also very important. Many studies show that it's infrequently done and it's often poor. That's why EPA is a very good tool for you to give immediate feedback, and feedback is very effective when it's immediate, and it should be based on direct observation. And literature shows that a lot of clinical teachers have expressed that there is a need for training. It has been seen that, and it has been proven that using feedback during the workplace-based assessments have clearly shown positive impacts. And this is very clearly documented in the case of surgical specialties where a lot of procedural skills need to be trained. Now, with this, I will hand over to Ms. Hanouf, who will guide you on how to complete the EPA forms on the NIHS e-portfolio. She will be the project manager, and she will be the contact person for any of your requirements in future.
Thank you very much, Dr. Fawzia. Hello, everyone.
You're welcome.
First, I'd like to introduce myself. My name is Hanouf. I'm handling the Entrustable Professional Activities EPAs at NIHS, and also I'll be your guide for navigating the NIHS e-portfolio platform. So NIHS e-portfolio, it's a comprehensive tool for workplace-based assessment. It's cutting-edge platform designed to enhance the medical education experience for both trainees and educators. By streamlining the process of workplace-based assessment, the platform facilitates a more efficient, effective, and engaging educational journey. The platform provides a single centralized location for trainees to store and access all the EPAs and case log. By keeping everything in one place, trainees can easily monitor their performance and identify areas for improvement. The platform allows you to complete EPAs forms as opportunities arise during clinical practice, whether it's for receiving feedback or being signed off on a specific activity. The key benefit is the ability to complete assessment in real time within the clinical environment, ensuring timely feedback and entrustment decision. The NIHS e-portfolio platform is accessible as a mobile app available on both the App Store and Play Store, and the app is designed specifically for trainees. For signing in to the app, your coordinator will be given access to the site, and you will train them to create user accounts for both your trainees and BD, and the sign-in option will be the UAE Pass. So after signing in, you will be presented with a homepage that reflects your specialty. The trainees will select the relevant EPAs form from the homepage form list and complete the form. If you do not absorb any of the milestones mentioned, you have no applicable option there to click on. The form requires sign-off. The trainees will ask the assessor to complete the sign-off field at the bottom of the form using their full name and work email address. And once the assessor has signed off the form, you can click on the submit button. Let's go through the form options. You have delete button. This will delete your current draft form if you have opened it with accident or a saved draft that you no longer need. You also have save and close, which will allow you to complete your draft form later. When you click save and close, you will see a number in bracket next to the complete new button, indicating how many drafts you have of that form. The next button is email for later. This will allow you to send a partially completed form to be completed. And the final button is submit, which will finalize the form. The same for case log as well. The program director will have access to a dashboard that provides an overview of each trainee's progress, and the program director can also bring the filled EPAs forms to this clinical competency committee for discussion and evaluation. We are currently working closely with the developer team to ensure the quality of the app and the platform. While we can't announce a specific launch date just yet, we can share that exciting news is on the way. NIHS ePortfolio is more than just an application. It's a comprehensive solution designed to enhance the medical education experience for both trainees and educators. And we are paving the way for a more efficient, effective, and engaging educational journey. Thank you very much. And the floor is open for questions.
If you have any questions, we would be happy to respond. If you would like to talk, you could raise your hand. Yes, Dr. Aisha.
Hello, good afternoon. Sorry, good evening. Thank you
Good
so much
evening.
for the presentation. It's been much enlightening, because reading about the EPAs, and no matter how many guidelines, American or Canadian, it won't be as easy. Now, my concern or my question is about the actual application on actual ground. My faculty number is a ratio of 1 to 1 almost. And let's say that we are in a setup where they are dealing with a team of residents, like such an inpatient house. And the faculty could be only two faculty at a time. How practically is it possible now, knowing that there will be an app coming in soon, compared to the new innovation, which it has its own build-up EPAs, I believe, in it, which is a bit complicated. So knowing that piece of information is really, really great. But on real ground, how is it possible to do a direct observation and a timely evaluation and fill in the form consistently for an entire academic year, where some rotations, it's not 1 to 1, it's like 1 to 4 residents at a time, or 1 or 3 residents at a time? Thank you.
I may try to answer this question. Can you hear me?
Yes, please.
Yeah, okay. So that is a question which I think it's in very many minds, given a PD and or a faculty. And thank you for this question, because I think this is the biggest worry of everybody when it comes to, oh my God, this is a new thing coming. You are right. We have to dedicate time to our faculty to supervise and to assess. But what is instead of it? What do you have instead of it? What other method to make sure objectively that your resident is able to perform without a direct supervision? Without this tool, you are mandated to observe all your residents directly until the last day of their training. This tool is actually helping you to direct observation, to have direct observation only for the residents in need, and then to slow down or to waive out that direct observation from the trainees which already passed that threshold. So it's helping you to have a better economy of the resources for the trainees. On the other hand, with your question in mind, we were thinking about which is the shortest, quickest, best way to help the faculty to do the assessment. So that's why we developed this app. That's why we developed it in a way it can be on a telephone, it can be everywhere at the workplace. The assessors, they don't have to travel anywhere. There and then a short feedback, it's given, a tick, 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 tick box when they have the memory fresh event. It takes a little bit time for adjustment and implementation, yes. But I promise you, once you do this again and again and again, it will take less and less time. It will be time consuming in the beginning. I think so. I think so. And you are right, it may take longer in the beginning. But as the faculty are going, they will become more familiar with the whole process, and it will take less. I hope I answered the question.
Thank you so much for answering. And that's one part of it. The other part as well is dividing. I mean, I know that this is a program specific, but is dividing or keeping a bunch of EPAs specific for PGY level is easier. For example, some for pediatrics, I work in pediatrics, some things are not expected as a milestone of an R1, while it is expected from an R4. But sometimes you get, for example, this extraordinary or somebody who's got the job immediately figured out. And for example, they are cutting their milestones all the way to 5, for example. So maybe this question as well for Ms. Hanouf, will the EPAs be designed by program available, or the EPAs are available at one go and it's the choice of the faculty to choose from? Should it be the faculty's choice, or is it a mutual understanding of the rotation needs and the resident himself?
I will answer again. The PD is the master of the implementation of the EPAs in the program. You are the Minister of Health in your own program. So that implementation of EPAs will allow you to identify, as I said, the slower and the faster. And if you have somebody who is a very fast learning, you have to give them opportunity to develop. Nobody will penalize a PD, which is giving more opportunities to a faster learner, because demotivating them, it's a crime. I totally agree with you. We are given that selection of the levels of the EPA based on the recommendation from scientific committees. So in the scientific committee for that specialty, all the members of the committee thought that at a certain level, this number of EPAs had to be completed. But there is nothing to say that if somebody completed the EPAs and they want to go faster, they shall not be allowed to. Of course they will. So yes, you're right, it's the PD which ultimately decide what to do. With one amendment, I don't encourage to give difficult EPAs or complex EPAs before the common or simple clinical EPAs. That's the only rule. Other than that, the PD is the master. Did I answer the question?
Can I add something?
Yes.
Yeah, in addition to the decision making, which Dr. Teodora very clearly explained, on the system, how it appears is that there will be the current year, and in the current year, the EPAs which are mandatory for the current year will be mentioned, and there they can click the link and go and fill those EPAs. There will be another section below on the same dashboard, on the same web page, which shows all the EPAs. So if the trainee so decides or chooses to do another EPA, which is not mandatory for this year, but it also needs to be done, the trainee can go and work on them as well. I don't know if this was part of the question, but I wanted to clarify how it will appear to them. So it will be possible for them to do. The decision has to be made by the PD, and already Dr. Teodora has explained that the decision has been that they can do any EPA which they decide to do.
Yes, the question has been answered clearly. Thank you so much.
Okay.
Dr.
Thank
Salam,
you, Dr. Aisha.
you can unmute yourself and ask your question, Dr. Salam.
Dr. Salam? Dr. Salam, your hand is up. Are you trying to unmute yourself? We cannot hear you. Could you use the chat box? Yes.
How are you? Thank you for you and for Dr. Dora. It was really a nice discussion, Dr. Fauzia, but I have one question regarding the trainees. Are they aware of the reasons when they will be dismissed from the program, or what are the conditions that will lead to dismiss someone from the training?
This is not with respect
I think I will
to
answer
EPA.
again.
Sure.
So every program should have clear policies about the progression, promotion, and dismissal. So these have to be one of the program's policies. It has to be there. Every program needs to have that. And the policies of the program have to be acknowledged by the faculty and by the trainees. But
so they are aware before they start.
Yes, the policies are in the program manual. It's part of them, together with the leave of absence, and all the policies of the program shall be clear and shall be in a manual which is accessible to the faculty and to the trainees. This is basic rule. But then what I was saying is that the non-completion of the EPAs could be taken seriously in consideration when somebody is not promoted or even dismissed from the program. So if you have a learner which is slugging back, who is not progressing, will you allow them to go to year 5 and then to realize that they did not even achieve the level of year 2? For what?
Good.
Give them time to remediate, and if that is not done, I think it's fair not to play with somebody's time, faculty time, hospital time, patient's time, and not in the end the learner's time, and give them the opportunity to choose another path in their career, earlier than later. That was the reason we said so. But the policy of the program should be very, very clear about that.
Thank you, Dr. Teodora. It's very clear. Thank you.